What is up, everybody, and welcome back to another edition of the NewlyMeds Podcast, a podcast made by new paramedics for new paramedics. And today we're going to be talking about some things that we've all done and all been in the field. And it's where you walk in, the vitals look good, the patient's talking to you, joking around, but something just doesn't feel right. Something's not adding up. And then all of a sudden, you're starting to get ready to package this patient, and everything goes sideways. And today we have another special guest joining us with Dan and I. I'm going to introduce Devon, another new paramedic to the podcast, and he's going to bring in another perspective for us to all talk about. So, Dan, Devon, welcome to another episode, and I'm really excited for what we have today.
I'm glad to be here, and Devin, I'm glad you're here with us as well.
Yeah, absolutely, man. Thanks for having me. Always.
So, if you wanna give a just a real quick elevator pitch of who you are and why you're here.
I don't know why I'm here,
There,
but I'm Devin. I'm a new paramedic. I work for a couple new companies now, actually, but yeah, I've been a paramedic for about 6 months now, so brand new.
awesome.
But just finished up school. Been an EMT for 5 years, and yeah, just working through it. But
Well, I think you
excited.
answered the question there is why you're here is because this is why we're all here, right? We all have a ton of or a ton of questions when we're new, and I think as Will and I have talked about on numerous occasions, being able to talk about all of these different topics with each other and together helps us both grow in the profession as both paramedics and clinicians in general. So, Will,
100%.
I think to start this off, this is like we said, this is going to be our newest iteration of the quick crits. We're going to just do some real quick down and dirty conversation on some of these red flags that we can miss, what the importance of not missing them are, and why we might miss some of these red flags. And I think one of the first things that when we have this conversation that we need to talk about is why we're missing these red flags. And the first thing that comes to our minds when we're thinking about this is pattern recognition. And we talk about pattern recognition a lot as paramedics because in and of itself is not a bad thing, right? Understanding these patterns and how they unfold helps us develop and hone in on these skills of our assessment and of our history taking and of making good differential diagnoses of various patient presentations. However, just because it can be a good thing doesn't mean that this also can be a trap that we fall into. I think the problem is we start to see some of these pieces of the pattern coming together, and we automatically assume we know where that's going, and then we shut our brain off. We're fast, we're intuitive, we're get to the next step, and let's keep it moving. And as soon as we start to see that pattern forming, we move on to the next thing and completely miss what turns out to be a red flag. So I think when we're thinking about this pattern recognition, understand that yes, we use these patterns to help make these differential diagnoses, but understand that just because we start to see a pattern forming doesn't mean that we can stop there. We need to let it run its full course before we move on to the next step. And I think that kind of couples in with the next one, which would that we came up with, which would be tunnel vision, right? We've talked about this in previous episodes where you have dispatch information, you know that you're going to a nursing home that might not have the highest standard of care, or you're going on night shift to a section of the city that is known for large amounts of drugs, or you have something that you before you ever even get up out of your chair from the computer is predisposing you to thinking that you know what you're going to. And that can, I would argue, is one of probably the two biggest reasons that we miss things. We go in with this tunnel vision of I'm going to a known drug house, therefore it's drugs, and we miss a septic or a hypoglycemic patient or fill in the blank patient, right?
Right.
And I think that's one of the big ones there. We start collecting data. We stop collecting data as soon as we think we solved the puzzle. And if we think we solved the puzzle before we ever even got up from our computer, we are setting ourselves and more importantly, our patients up for failure.
Yeah, 100%.
I think one of the things too, I know, Will, we've worked quite a while together. And Devin, I know you said that you're working multiple different places, and we're all just as guilty of that as well. And that leads to one of the, I think one of the most significant ones is fatigue. We're 12 calls deep in as many hours. There's no end in sight. The calls keep dropping. Haven't eaten, haven't gone to the bathroom. The hospital's backed up. You're holding the wall. Fill in the blank. It's just been a shift. We've all had those shifts, some more than others, but we've all been there. We've all done. And you get a general malaise, hasn't been feeling good for 2 or 3 days, just wants a ride down to the hospital. When we start talking about some of these red flags, while that sounds, potentially benign off rip, that could turn into something very serious. We need to do better as providers, and we need to do better, honestly, as a profession on managing fatigue and burnout and not letting providers get to the point where we start to let these feelings cloud our. And I think, speaking of clouding judgment, I think the last one that I have that we kind of came up with collectively, that is a huge trap to fall into, is familiarity. We all have our, um, I think frequent flyer has such a negative connotation. I like to refer
Yeah.
to these individuals who are loyalty rewards members.
Yeah.
Um, you get one punch away from a free trip type deal.
Yeah.
And I say that in jest, but also we have patients that we are very familiar with.
Mhm.
I have, both jokingly but seriously, have mentioned before in the past that at one time I had seen this patient more in a week than I had seen some very close loved ones. We have these patients, and it could be 99 out of 100 times that their same routine complaint is nothing, and they go to the hospital and they get discharged for the same thing over. And then it turns out that the time that you let your guard down is when they are sick, and you miss that because it's, the children's tale of the little boy that cried wolf, right? That is very real. And that's not, and I'm not saying that in a negative light on the patient for being in that situation. I'm saying that's negative on us for allowing us to fall into that trap.
Mhm.
And when we think about these, it's, a lot of it comes down to feeling rushed, feeling possibly in a mental rut, or possibly, Devin, not to pick on you, but you're here, so I'm going to pick on you a little bit. I know we all kind of go through that window where we're finally starting to get in our routine as new paramedics, and we're finally starting to feel good, and we're finally starting to think that we have it all figured out, and then we kind of hit that proverbial wall where we kind of get knocked down a couple pegs. You could, and I'm not just saying you, but anybody at any stage of the game, myself and Will can also fall into this as well, where we are feeling good, we are feeling confident, and I'm feeling grounded in my assessment skills, and I'm feeling grounded in my treatment plans, and then I just totally something, right? So I think we need to make sure that we are honest with ourselves and our partners, and having these types of conversations that we're having right now, to make sure that we can work on ways as a station, as a company, as a crew, as an individual, to kind of make sure that we're not falling into these traps. But when we start talking about these traps, Will, what are some of the red flags that we're missing?
Yeah, Dan, I thought you made a ton of great points. And just to circle back before I get into some of these red flags, I've had the privilege of running calls both with Dan and with Devon. I've gotten to work with Devon in a training capacity. And so, I think that's the amazing thing about being a new paramedic and also being a experienced provider, because at this point I by no means have worlds and great depths of experience, but I've been going at this for a little bit of time now. But I think Dan said the biggest thing that I see all the time is as soon as you get confident, you start to miss things. And Devon's run calls with me before where he thinks that like there's nothing I can't do. He's like, Will knows it all. He diagnosed all the 12 leads, and then all of a sudden I sit in the back and Devon sees me going with a blank stare, and he's like, something got him. And it's just those oddballs. Is as soon as you start to get overconfident, you miss something. So always trying to keep that humble state. But what are those things that you could miss? And so some of the big red flags that I look out for are my patients that have extreme diaphoresis when they have no exertion. It's your patient that's sitting on the couch watching TV after dinner and looks like he just got out of the shower. We want to make sure that we're not writing that off. That could be some sort of cardiac event, that could be an MI. And so, another thing that we often miss are clinical signs of sepsis. So, someone who's preseptic might be very diaphoretic, super sweaty, and this could be delayed in the process if we're writing off that sign or just not picking it up on the assessment. Another thing on that note is mild tachycardia or hypotension. And oftentimes, when I think of my septic patients or preseptic patients, someone who has a heart rate of 108, 116, and they're just sitting on the couch, that's not always the most normal thing, right? I always would think of someone who might have some sort of infection or some sort of hypotension, and now they've got this increased myocardial demand that's increasing their heart rate, or even this hypotension. Why is their BP all of a sudden just as they're hanging out 90 over something, or even after that middle-aged male said, "Yeah, I was just mowing the lawn outside, and I came in because I wasn't feeling good, and his blood pressure is now kind of in the toilet." We don't want to miss those signs and symptoms. And then a huge one that I see is altered mental status or just a little bit of confusion. Someone who, again, your middle aged male was out just doing house chores and now he can't remember what he had for breakfast or he doesn't remember where his wife is. What does that change? Is he having some sort of neuro response? Is he having some form of sepsis? Is he having a MI? Because we got to understand that all of these clinical presentations can come in multiple ways. So picking up on the small cues are huge. And I know that Devon even has a few more that him and I have talked about as a new medic that he looks out for. So Devon, why don't you tell everybody some additional things that you see that might aid you in picking up on these red flags?
Yeah, I mean, I think you hit the big ones for sure. Like you said, that diaphoresis is huge, and a lot of the times it's overlooked. Um, I mean, it goes down to as well as those patients in the nursing home where they thankfully they have a Foley, and I mean I've had it, you've had it, where you're sitting there and you take a look and it just looks gross. It's cloudy, it's dark, it might have a little bludge tinge to it. And you ask the nurse and you're like, when was the last time this was changed out? They can't tell you, they have no idea, or they're like, just changed it yesterday. Sounds good, perfect. The patient's probably septic. I mean, you can look at that, you can do that. Um, that is a huge thing. Pale, mottled, discolored skin. That's something that is overlooked all the time. Um, it's hard to tell with a lot of different patients and their skin colors as is what's baseline for them. But truly mottled skin is something that you're not going to miss. That is, I had one recently that we brought in that was a trauma patient. Um, just a fall on thinners, supposed to be your day to day regular call. And we got there, and this guy was modeled from basically his chest line down to his toes, and I mean the most modeled skin I've ever seen in my life. Um, that guy was severely septic, severely hypoperfused. I had a partner with me that I don't speak ill on anyone, but kind of just overlooked that altogether, and was just going on this is a BLS call. This is a fall on thinners. This ain't anything. But recognizing the hyperventilation, the story, the baseline of the patient, something just didn't feel right, and caused us all to do a little bit more investigation. Um, you have those patients as well that are just something's just off, right? They're not sure what it is. They can't really articulate what their problem is. They just don't feel well. You got to take that as is, and really do all of your clinical diagnostic tools. Use it all. Do a 12 lead on almost every patient. Just do your research. Don't get lazy. You can't fall into the fatigue. You can't fall into that trap. And really do the best that you can for these patients. Um, Anything feels off to you or feels off to the patient, it probably is. They're calling for a reason. You
Yeah.
can't just overlook that.
No, absolutely. And Devin, I think that is one of I know Will and I have talked about this in the past, and I would imagine that you would agree. Feel free to let me know if you don't. But I think one of the scariest things that I hear is an elderly female or male, but particularly an elderly female that just doesn't feel good, just doesn't feel quite right. And not that, oh, I've just been, I've got the sniffles for the past day or two, but she's like, I don't know, just something's not right. You are correct in saying, Devin, that something is probably not. I've had far too many of those types of scenarios where something was in fact not right. And I think that brings us real quick to our last segment here, where I think it's important. We've said this numerous times over and over that sharing these types of calls, sharing these types of experiences is with each other as partners, with each other here in the community that we're trying to build here is incredibly invaluable because this helps number one humanize all of us that there are times where we're going to miss things. And it also helps to put all of us on alert on things that we should be looking out for as well. So I know real quick, we're just going to kind of go around the proverbial room here and share a couple of our quick catch or a quick catch and a one that we might have missed along the lines here. So when Devin brought up the person that's just feeling off, not feeling quite right. My catch in this scenario, mine and my partners, I'm not taking full credit obviously, but we had a patient laying in bed just not feeling good. 2 days, just didn't really feel like getting up, fatigued, not feel good. Start to go to get vitals, pressure's fine. Pulse ox wasn't working. The service that I worked for at the time, that wasn't a surprise. From an equipment standpoint, the pulse ox wasn't working. I didn't think anything of it. I would probably classify this as a near miss because I didn't really think anything of that at first. And we go to like reassess the vitals, blood pressure's still good. I'm like, man, I still don't have a pulse, and I go to feel for his radial pulse, and I just can't really feel one. And what I think I feel is through the roof. We do a little bit more digging and a little bit more assessment, and this gentleman is in VTAC. So had I fallen into that trap of, oh man, my pulse ox doesn't work. It's another day here at fill in the blank company where my pulse ox never works, and not have felt for his and did an appropriate assessment and felt his pulse and put him on the monitor. We very well could have taken a patient in VTAC into the hospital, or worse, when we go to try and get him out of this residence, he could have completely crumped out. So I think that was one example of that where we fortunately did catch that. One where we completely missed it and didn't even think about it until after the fact was an elderly female dementia patient. Husband called for increasing altered mental status. And when we get to her, she has no complaints other than, and I quote, my ass hurts. Other than that, she's completely fine. And the husband even noted that she actually seemed more with it than she has in the past several months. All right, cool. I mean, sure. Yeah, we'll still definitely take her down to the hospital. We stair chair her out to the vitals are all fine. Vitals are all perfectly stable within normal limits. We get her out to the ambulance. We use the stair chair. I go to pack the stair chair up, and my partner pokes his head out the door and says that he needs me. And I go in, and we're working a code. Now, I don't believe that anything that we would have done was preventing that, but those subtle changes that we didn't even pick up on until we were analyzing this call after the fact, those altered mental status doesn't necessarily mean confused. A confused patient that's now cognitive and with it can also fall under that altered mental status. So make sure that we're picking up on those types of things because I know I didn't until after the fact on that. Gentlemen?
Yeah. No, yeah, one thing that immediately comes to my mind, I sort of want to start out with something that I caught because I think it's really important to leave you with some of the things that you miss so that I always say the biggest mistake we make in EMS, but really in the field of medicine as a whole, is missing something and not learning from it. That's really the only mistake you can make. You can't make a mistake as a clinician if you just do something wrong, as long as you're learning from it and improving it. And so it's the ones that we miss and we don't learn, we don't improve, and we just let it go, and then you miss it again, and you miss it again, and you miss it again, that sort of gets you with your pants caught around your ankles. But one that I can remember catching is an elderly male. Didn't really have any reason to do a full assessment on him other than the fact that he was kind of tachycardic in the 130s. And I found out that he was probably septic when I did a sacral exam, and I realized that he had a massive sacral wound. And so that's sort of the nurse in me coming out. I was like, let's just roll him and look at the backside, look at the butt, look at the skin, like a good ICU nurse. And then I find out that he's got a big old sacral wound. And so I was able to catch that he's probably either pre-septic or going down the septic pathway. But one that I immediately think of that I missed, I was a very, very green paramedic at this time. I think maybe either still on orientation or just off orientation. And I walk into a residence. There's a very young female in there. She's telling me that she can't breathe. It looks like she's having a panic attack. And I'm like, oh, she's having a panic attack. And I'm telling her, like, hey, if you don't calm down, you're going to pass out. Lo and behold, she passes out. Her boyfriend comes out of the shower. He tells me that she was in the hospital earlier that day for a blood transfusion, which is apparently not super uncommon for her. And the next thing you know, as I'm stair chairing this young female out of the house, she goes into cardiac arrest. Um, it took a lot of conversing about the call and some research on different disease pathologies and processes to find out that she had a transfusion related acute lung injury that oftentimes presents just like a panic attack, and it's very hard to identify clinically. I don't think after researching the topic that the outcome would have significantly changed if I would have noted it earlier, but that was nowhere, and I mean nowhere on my list of differential diagnoses. I didn't even know what a trolley was. There's also another one called a taco. I thought that was just something that I love to eat. And I found out it's these transfusion related injuries that can occur. And it nowhere was it on any sort of radar that I had when I was going to that call. And so that's why it's so important to understand these misses and to learn from them so we don't keep making the same mistake. And so I now want to pass it over to Devon. You've had 6 months of experience. I'm sure you've had numerous occasions now to where you've had the spidey senses go off and then you're like, what the heck is this? So why don't you tell us about it?
Yeah. So I mean, first one that really comes to my mind is of course recently. I had a patient that was just general weakness, wasn't really feeling well for at times like 5 days. She was elderly female. We get there and she's conscious, alert times three. They're basically relaying to us that this is her baseline. Um, Patients has a known history of dementia, and nothing about the call was really seeming right. She was bruised up, doing that skin the skin assessment that you do. I mean, you note that something's not right. She's had a lot of falls. You can tell this from old bruises. She's discolored all through her skin. She just looks kind of jaundiced. Just doesn't look right. Um, but they said she just isn't feeling well. She doesn't want to eat. She doesn't want to drink like she normally has been. Um, when we did this uh, patient, obviously, we started with the normal full assessment of a 12 lead, 4 lead. We checked a blood sugar on her. Everything was kind of looking normal. It was all good. Um, but again, we were having a problem getting blood pressures. That patient was very frail, small. Blood pressure cuff wasn't really fitting right. BLS crews weren't able to get one. We finally get one from the auto cuff, and she was about, I want to say, in the 80s systolics. So I mean, she was hypotensive. We're like, what could be causing this? Here, she had a port in her skin um, for apologies. I can't remember exactly what kind of cancer it was, but anyway, she had cancer, had a radiation port, and this thing was bad. I mean, so that was a source of infection for us, telling us that she was septic. But um, we were going to just load and go type of thing, but it took a little bit of extra time to do a full assessment of her skin, see exactly what's going on. We recognized that she's probably septic, and this chance that's what's going on, and she was. Um, Oftenly, I want to say I fall into the trap a little bit of getting burnout like anybody else with certain calls, where you don't want to do your 12 leads, you don't want to do things like that. But I've had great mentors that that have really drilled it into my head of just do it on everybody, do it just to do it. Um, Helps you learn, helps you see things. Luckily, I really hate to say it, but I haven't missed too many at this point. I had one that again I had caught, that was a stroke patient. Came in as a stroke, looked like a stroke. It was a stroke, but this patient was also in a second degree type 2 whenever we did a 12 lead and did the 4 lead and things like that, which was attributing to the hypotension that he was dealing with. Um, so thankfully, I caught more than I have missed. I'm sure it will come, and I think that's a huge thing. Is you just gotta stay on top of it. You can't fall into the trap. You have to stay humble. I mean, patients are. It's never going to be straightforward, no matter what you do. It
Absolutely.
just isn't.
Yeah, I think that's such a great point. And so, really, to wrap up this episode, um, I just want to say, Devin, thanks for coming on. Thanks for talking about some of the stuff that you've seen in the field and that you've done. And I think you left everybody with really a remarkable statement that you haven't missed anything yet and you're super glad about that and it's fortunate, but as we continue our path in medicine we have to understand that this is a practice, and so at some point you are bound to not see something or not do something, and truly the only mistake you can make in medicine is not learning from the mistakes that you make. There's no real mistakes as we're practicing this and medicine evolves except for not learning from it. So to leave you all, we want to hear from you. Why don't you leave a comment on the YouTube or the TikTok or the Instagram and tell us what you've missed? Shoot us an email. Let us know some of your stories. And as always, trust what you know, treat what you see, and always remember to stay curious and stay humble. And we'll catch you on the next episode.
Thank you guys.